and then I did my pediatric neurology residency. After that, I did my fellowship in epilepsy in Brazil, and I moved to Denmark to continue my studies in finding some useful clinical variables to help uh, people like you and your sons and your siblings. So I don't know if I can hold on. So I have no conflict of interest, and I want to start by thanking you guys for the amazing job you've been doing with creating the alliance and all what we do here in the lab, all that we do here in the mouse models, the IPS cells, and the organoids is about these people. Of course, there are a lot more that are not in the picture, but I just want to acknowledge that we are stronger together and that we are doing this for those smiles that are in screen. So I'll start with an overview about what's GABA. Then I'll start going about telling you about what is a variant, because of course I have been in contact with Charles. He's here in neuroscience, but some of you are not related to the field, so I would like to have a plain summary of it. And then I will kind of show you what the variants are, and then what we do when we are talking about functional testing. And then at the end, I will show you how are we planning to describe the trajectories and the characteristics of the patients. And of course, I have received 2 or 3 questions, but I would love to have a lot of questions from your end. And also, if you see that something is missing, that you think that it's worth doing some research in other ends, please just let me know and we will work hard to get to your point. So as you might know, when we are talking about GABA, we are talking about 2 different things. One is the neurotransmitter, that it's a molecule that acts on a receptor, and the other ones that we usually refer to as GABA-AR, it's the actual receptor. So the receptor will be like a door that opens only to this molecule that it's called GABA, and it enables that the chloride, which is a small molecule that it's usually by a negative value, enters the neuron. And the negative value, it's important because as you might see in other studies and in other presentations, the neurons, in order to communicate, needs to be positive. So you need to change the electric field, go from a negative steady state to a more positive, so they can communicate in between each others. So we have 2 types of receptors. Ones that gives us the phasic inhibition, which is an immediate, very short response that blocks the communication between the neurons, and then the tonic inhibition that actually prevents another depolarization or communication in a different way outside the synaptic cleft. So the cleft will be the space between the neurons. So that's where the phasic inhibition happens, and then the tonic inhibition will be outside this cleft. And as you might know, the GABA is produced via the L-glutamate, this carboxylase. And this is why in some cases, I will jump in a little bit further, ketogenic diet can play a role in the treatment of the epilepsies. Because of course, all the modifications that we do on the Krebs cycle and also in this LGD can change the amount of GABA that we have. So once you have a patient who is having seizures or developmental concerns, we start using different tools and different approach to find the etiology. And in this case, the etiology that we are trying to look at comes by a genetic report. So you can have a genetic report that says that it's a substitution, which means that in the case that you see here, there's supposed to be different DNA pair bases, and it has changed. But the change is occurring only in 3. So the transcript or the way we read is just not modified. So we change, let's say, yellow to green, but not another kind of variants that I will see afterwards. The next one will be deletions. That means you will find in your reports, it will be like a number and then the word deal. That means that one pair or several pair of bases are deleted from them, and then the way the protein is read, it's changed. So that will be also what we call a frame shift. That means that when we are trying to read, something is missing, and then the other things are occupying different positions that would lead either to a different protein or a non-functioning protein. Also, you can have insertions that are events, genetical events, where we have one or several base pairs that are inserted into the genome. So then again, it will be a different type of reading because we are inserting a different number of pair bases. And as you remember, every three pair of bases codifies to an amino acid. So if I change one or more, then the amino acid will change, and then the protein structure will be different. And also we can have inversions, which means that the position within the protein, within the DNA, sorry, are switched, and then this can lead again to a different protein uh, structure. Sometimes we have a truncating variant. That means that we have a pair of bases that says to the RNA that it's reading the DNA, stop, don't continue, because there is a stop codon, what we call, so the protein is incomplete. And this is also very frequent in patients with loss of function. Why? Because the protein is not there. Once the protein is not formed properly, the body will discard them. It's a non-mediating decay, what we call in this case. So this can help you guys to see on your child report or your relative report whether you have a deletion, you have an insertion, you have a frame shift, you have a truncating variant, and so on and so forth. This is the first step. So we have a patient that have some symptoms, and then we do the test. So the first question is, why aren't testing if I don't have any other uh, direct treatments or possible not a lot of implications with regards to prognosis? So to make things even more complicated, we do know that the protein itself, it's not the only reason that the channel is not functioning, can be also the connection within the proteins. If you compare, it was a question comparing this disease to a different disease, the genetic disease like a Dravet syndrome or STXBP1 or SNAP25. The main difference is that in this case, the GABA receptor, it's assembled by 5 subunits. So we need 5 proteins to form the pore. And in the case of alpha-1, we have variants in alpha protein that usually we have 2 of them in each channel. Can be also beta-1, beta-2, beta-3, that we have also 2 of them in the channel. And then we can have either gamma or either delta. So as you remember, delta, we only have 15 cases reported in the literature. And then the gamma, it's a paper that it's about to come out probably early next year, that we have roughly 40 patients by an international consortium. So again, it's not only the number that we have in the genetic report, it's the implications that the protein that it's modified has in this channel. So you might find in different papers the figure that it's here. It's a linear figure where you have, this is what we call the extracellular domain. This is the cellular membrane or the wall of the cell. This is the transmembrane domain, and then this is the intracellular domain. Of course, this is only a graphical representation because what we have is a protein that looks like this. It's a very complex with beta helixes and alpha helixes and beta folding that it's actively opening and closing. So what we have seen, for example, in patients with variants in GABA, Sometimes, especially in beta and alpha, fever sensitivity and milder phenotype cognitive outcomes with mild and moderate can be located here in this region. The most severe phenotype that we have encountered in alpha 1 and beta 3, it's here in the transmembrane domain 1 and 2. They usually have a very early onset epilepsy with a prominent cognitive impairment. So what I wanted to show you in this picture is that what we are aiming to study is why this channel opens continuously, for example, in a gain of function, or keeps closed in a loss of function. So we need in this space for the chloride to go through and enter the neuron. So if you go to the textbooks, we often see GABA as an inhibitory neurotransmitter. So the discovery that our lab did in 2020 or 2019 about that variants can actually be gain of function, it's somehow counterintuitive because, of course, if you have a lot of inhibition, then probably you shouldn't have epilepsy because epilepsy by definition is a hyperactivation and hypersynchronization of the neurons. So we are trying to find the path where inhibition can lead to severe activation. And probably it's about the pathways that are involved. So until now, do you have any questions regarding the protein or the variant? Okay. So once we have found the variants, we either go to our database and see if the variant has been tested, or if not, then we will go to the lab and prepare a construct. So what are we going to do with the variants that have not been tested, or the variants that we have tested in the past? So let's say we have a patient with a variant of beta 3. You will find here a little star. So we make a strain DNA that has all the five channels, and we have only one variant in one of the channels. As you remember, this is an autosomic dominant disease. So with one variant, we can have the disease. So what we are aiming to do is to express as much as natural as possible. That means that 25% up to 50% of the channels that we are expressing in this frog egg have the variant that your patient or your daughter or your son has. And then we will expose them to increasingly concentration of GABA and see how do they respond. So we'll put an electrode outside to measure the amount of current that it's outside, and then one electrode in the inside to see how are the differences. So if you go to the bottom line, remember this is the structure of the protein. So this black line will be the wild type. This means that we have tested normal or non-pathogenic variants. So we know how the curve is in response to different concentrations of GABAergic medications or enhancers. So if the curve goes to the right, in this case, the red line, this will mean that we have a loss of function. And as you can see here, the channel is not working despite increasing amount of concentrations. This is the wild type that we expect to have a small, but then increasingly potentials after 100. And then as you can see here, in this case, it's a later appearance of the activation. Whereas on the other hand, if you go to the blue lines, we have the gain of function. That means that the channel works very, very much, even with little amounts of GABAergic drugs. So now we know that if you have a gain of function, then the channel will be working a lot more and will be open almost all the time. Whereas in the loss of function, we will have to have an extra amount of GABAergic promoters that open the channel. So this is basically what we are doing with the testing. Of course, this takes weeks, if not months, because we need to ask for the construct, then we need to build a DNA chain, and then we need to implant that in frog eggs. And of course, this is nothing that we can do over the night. So I can send you the papers that we have published, so you can understand a little bit better after this explanation. So once we have tested the variants and we know that they are a gain of function or a loss of function, then we want to test how the patients behave differently, because we know for sure that some patients start very early, some patients start much later, some have microcephaly, some doesn't have, some have febrile seizure and normal CI, but some of them have movement disorders with a very severe and complex cognitive uh, issues. So we did a statistical analysis to try to find out whether we have significant symptoms that can resemble one phenotype without the testing. Because of course, when you have a report, you want answers. And if we are taking 2 to 3 months to just provide one answer, it's too much. Yeah. From a parent's perspective and from a clinical perspective, I cannot be sitting with a child and saying, okay, we need to wait 5 more months because we don't know the functional analysis. So in this case, what you can see here is that the red elements are related to the loss of function, and the blue ones are related to the gain of function. So what do we know now? Febrile seizures and seizure freedom are more likely to be and to occur in the loss of function group. And that's what we saw in milder phenotypes. Some of you can have the variant, some of you can have some febrile seizures in the early stages, and then you grow out of it, and then you don't know anything about epilepsy. On the other hand, we know that severe intellectual disability, uh, focal seizures at onset, hypotonia, and acquired microcephaly are all related to the gain of function. And again, this will allow the clinicians to know with some degree of certainty whether you have a loss or a GOF. Why this is relevant, I will show you in a minute, but I wanted to know that that's why in the interviews we have had with some of you, almost most of you, we have been asking a lot of these symptoms, because the bigger the database is, probably the stronger the statistical analysis will be. Of course, if we only have 10 patients, that will be insufficient to provide any kind of advice, but the more patients we have, probably the more likelihood of us finding commonalities. So as I told you before, this is about GABA beta 3. So we have key features for loss of function, febrile seizures, and then age of onset of above 6 months, supporting features that are no hypotonia and no microcephaly, and then features that we need to develop further, and that's why we are asking again for all the EEGs and the tracing so we can do a proper analysis. So whether the EEG is generalized or focal, and the cognitive testing. On the other hand, on the gain of function, we have a very early onset below 6 months with usually focal onset. That means that you have usually an asymmetric movement or a very early onset of focal seizures with resembles absences, but outside the time of absences. And if over the time the kid develops microcephaly, there will be an acquired microcephaly that will support the diagnosis of the gain of function as well as the hypotonia. So what will be the implications when you do the testing? So we have published this early this year, and it's about the response that we have to some GABAergic drugs. As you all know, vigabatrin acts on the GABA transaminase, and it usually is the first line, at least here in Europe, and also I think in the States, for treating infantile spasms, or what it was called West syndrome. So those patients who had a very early onset and were tested to have a gain of function variant, where they when they were put it on vigabatrin, they were seizure free, but they developed severe hypotonia, extreme somnolence, and difficulties in the breathing. So we came with the construct and we tested this hypothesis by measuring what would happen in these models that I showed you before when we put vigabatrin. And what we can show you is that if in the cases that we have tested, you put vigabatrin, then the channel will be leaking. So it will be super open all the time. And that will increase the inhibition. So again, more hypotonia, more drooling, somnolence, and you have seen this in several of your child. We are going to test in the future other compounds because the information that we have received from parents and caregivers about benzodiazepines can be conflicting. Most of them say that with clobazam is almost the same, but in some cases, clonazepam and nitrazepam can have a different effect. So that's why we are very cautious in giving you recommendations about drugs because we don't know actually if all benzodiazepines and all medications that act on GABA actually can produce this effect. But what we do know, it's in the cases of beta 3 that we have tested in gain of function, probably by gabapentin, phenobarb, and benzodiazepines can worsen the phenotype. So this is a paper that it was published a couple of years ago, where we described that we have a spectrum of the GABA alpha 1. And this can apply to all variants. I will show you in a minute. But what I wanted to show you is that despite your kid can have epilepsy, epilepsy is like you say a car has four wheels. It's not the same having a Ferrari that have a Ford truck. It's certainly different. So that's why the age of onset, the response to medications, and the trajectory of each kid, it's important. I will show you after that if your kid has what we call a genetic generalized epilepsy, let's say juvenile myoclonic epilepsy or childhood absence epilepsy, it's more likely for them to have a better cognitive outcome. So, Miranda, no, so the variability in the phenotypes, it's not necessarily related to the location of the variant. Probably will be the network where they participate. Uh, Remember that some of them can be outside the neuron and some of them will be in the wall of the neuron. So probably this could lead to different phenotype. I'm trying to read the questions in the, or maybe we can just answer after, Justin. What do you think? Okay, maybe I can just leave them to the final so we can read them out loud and try to go through it. So in this specific group of patients, coming back to the alpha one, what we used to call generalized tonic-clonic seizures that now are called bilateral tonic-clonic, and then the GEF plus spectrum that resembles very much a Dravet, patients with febrile seizures with a familiar background of other parents with febrile seizures. That's what GEF plus is. So in those cases, probably the cognitive outcome will be better. But if you go to the EEE and the Dravet syndrome like spectrum, that it's very refractory epilepsy with a lot of febrile seizures or very early onset seizures and epilepsy with migrating focal seizures, those will have a most severe phenotype. Of course, we need to think that if you have in your very early development seizures, that will hamper probably your outcome. While if you have already developed a certain amount of normal brain, then it will be a better outcome. So this is a very busy slide, but what I wanted to show you is that Here, oh, sorry, my mouse is not working. You have all the syndromes listed. Let's, for example, use this, which is epilepsy with generalized tonic-clonic seizures upon awakening. We know that the outcome of the seizures will be very good, which means they will be seizure-free. But in other cases, like the Dravet-like patients, we know that they can be with a poor prognosis, which means that they can have refractory epilepsy, with a seizure-free or somehow with some seizures. So even though we know the epilepsy syndrome, we know the age of onset, the epilepsy outcome, it's not a straight line. And as you remember, probably from your own experience, your patients can migrate from syndrome to syndrome. So having an Ohtahara syndrome, going to a West syndrome, and going to a Lennox-Gastaut syndrome. So it's a very dynamic thing. So that's why usually doctors go very straight ahead to treatment in the epilepsy field, because this it's related to the cognitive outcome. So, for example, you can see here that the focal epilepsy again can have poor seizure control, very good control, which means seizure free, or some seizures between weekly and monthly. So again, that's why the seizure diaries are critical for us to know the response to medications and the actual outcome of every kid. So what about cognitive outcomes? So we can also make the same assumptions with cognitive outcomes, and we need to do here a disclaimer. If your kid is below 5, then we are talking about neurodevelopmental delay. And that's why usually you will find a lot of uh, hesitation from the medical field saying, I don't know, or I will know what the prognosis is. Because as we saw with the epilepsy field, also here, we can see that you can have different outcomes in different epilepsy syndromes, or in the same epilepsy syndromes, different outcomes. So we need to know what are the trajectories of each patient so we can actually provide accurate information to each one of you. So this is related to the age of onset, and the age of onset it's epilepsy onset, but also symptom onset, because some of you, if I'm not mistaken, haven't had seizures in your life, in your kids, but developmental concerns can start in a very early age, like a year or so. So in these cases, we tested and we know that, for example, if you have severe ID, it's more likely for you to start very early, less than 3 months. But again, you can come from every group, 3 months, 4 to 16 months, and above 19 months. So again, we think that there is a tendency for us to have the less severe phenotype with very late onset. And we're talking about late onset, we're talking about above 1 year and a half. Between 3 months and a year and a half, there will be the gray zone where you can have some features of the gain of function, some features of the loss of function. But if you go for the first trimester, it is likely for you to have a cognitive outcome that is worse than the other cases. This will apply also to the epilepsy, to the cognitive, and motor development and language development. So, what is the main problem? The main issue we have had with the motor assessments is that they are measured in different ways. We can say whether the kid is ambulant or non-ambulant, but we think that we will lose a lot of information, because of course, if your kid can walk, maybe walks 5 steps, and other can walk a mile, and that will be a major difference. So we will distribute some scales that are validated to see how the motor development is, as well as words and language, because again, it's not the same you say one word sentence if you say 5 word sentence, or you can read. It's a complete different scenario, but then all of them are verbal. So we need to go deeper in that, and that's why sometimes a lot of questions comes from our end with regards to the development of the patient. So again, this will be my last busy slide. This is how the trajectories of the patients are. So sometimes when you have a patient and you put a treatment that probably is contraindicated, you can go from a very good outcome to a very poor outcome because the medication is not working. So what we are trying to show you here is from the location of the protein variant, that can be transmembrane 1, 2, 3, 4, extracellular domain, and the helices, you can have different age of onset. So most likely, for example, the truncation and the transmembrane domain 1 can start on the first trimester. And the extracellular domain, as I showed you before, this will be the love, will start between 4 and 18 and then above 19. And then will they have febrile seizures? Most of them, no. And some of them, yes. And some of them, yes, will come from probably the extracellular, the transmembrane 3, 4, and the very last part of the protein. So how a patient will start from here with an age of onset if they have febrile seizures? How is this related to the syndrome? So as you know, the classification is critical. So you need to know, and your physicians need to know whether this is an early onset epilepsy, an epilepsy with migrating focal seizures, and chronic generalized tonic-clonic seizures, because it does make a difference. And the treatment implications are very important. So if we don't know the actual syndrome, then probably we will miss a lot of opportunities in drug repurposing and measuring outcomes in the patients. So what about, let's forget about the epilepsy syndromes and let's go to the seizure type. Again, this can be very variable, but we know that if you have focal seizures with a very early onset, probably you will have a cognitive outcome that it's not good. So most of them are going down here to severe ID. So also we know that for some epilepsy uh, seizure types, we can have a poor prognosis in terms of seizure outcomes, partially good prognosis in terms of seizure outcome, or a very good seizure outcome. So this is a very busy slide to show you that the trajectory can vary from a lot of perspectives. So that's why you don't get always the answers you're needing, because we don't know. Probably in the upcoming months, we will have a lot of information that will provide us uh, more decision tools to help you localize the protein and then try to find specific treatments. But the kids can vary it along the whole life, and that's why we are gathering as much information as we can. So I would stop here and would love to hear you from you and have a discussion on the questions, because I don't want to bother you with a lot of clinical and boring stuff. I'm going to move myself.
I everybody unmuted. First, I think there was one more question in the chat from Randy, and then Miranda had one too in the chat, I think.
Okay, hold on. So the battery is running out. Should we read them and then try to?
Yeah, go back to Randy's.
So Randy Gabrielson asked that one of the doctors said that there was some GABA that could be found in the gastrointestinal tract and the muscular system. So if we do have supporting data, yes. So the answer will be yes, and that's why most of our kids have hypotonia. This is related to the muscle tone, but the muscle tone is not controlled by the muscle itself. Partially, it goes also from the central nervous system. So if you have difficulty in your brain, then you will have a muscle tone abnormalities, and also in the GI, because there is a nerve that it's called the vagus nerve that goes all the way down to the intestine. So most of these kids can have constipation several times per year, and requiring a lot of interventions in that regard. So it is important because, of course, if you have a gain of function and you use medications that will increase the GABA tone, they will have higher constipation and diminish the muscle tone. And it has been seen the muscle tone in the patients that have been treated with bigabatrin, for example. Again, the observations about clobazam are not that straightforward, pointing out whether they can or not improve or hamper the muscle tone. So the first question of Miranda, I tried to answer before. So have you guys also tried repurposing Ravicti? No, we have not tried. There is a report on an animal model in loss of function, and that shows some improvement in behavioral and seizure outcome. The main issue with Ravicti, it's there is no EMA or FDA approval for the use in epilepsy outside urea cycles, so that could be tricky. And the other one, it's the adverse effects that some of the patients have when they don't have an OTC urea cycle defect. So, but there is certainly a research area where they have tried this in animal models, and the outcome seems, let's say, as good as other type of drugs that we use in the loss of function. Randy, you're asking if patients with gain of function will be not exposed to GABA agonist in the past, will it mean milder presentation of the disease? And will this exposure to those agonists adjust function of the receptor despite we're stopped? So we don't know. I can tell you that this is the case in patients with Dravet syndrome, where they are exposed to sodium channel blockers for a period of time above 1 year, and this will have a severe impact on the outcomes in regards to cognitive function. So extrapolating that, we could argue that this might be the case, but we don't have any clear information that this is actually true. But from the Dravet experience, it seems that this could be an option. So are the functions of the GABA receptor being influenced by other channelopathies? Yes. We have one patient with a beta 3 variant that has also an SCN1A variant that resembles a Dravet phenotype, and he's severely affected. So that's why we think that this is a network disease and not only one gene, one disease. And that's why you have a lot of different clinical scenarios. The main issue is that some of the reports say, okay, you have this pathogenic variant, but they report a lot of VUS variants, that there are variants that we don't know whether they cause or not disease. So can be happen, and we have seen that for sure. Actually, it's an Italian patient and that has a SCN1A and a GABA beta 3, and his phenotype is very, very severe. So Agustina is asking if we have any experience with lacosamide in love. There's limited data. I can tell you that on Alpha 1, we have 3 or 4 patients with lacosamide. But what we have seen in the love group is that they can respond to sodium channel blockers and valproic acid. So lacosamide is in the group of sodium channel blockers within carbamazepine, carbazepine, lamotrigine. So it's within the same family, quite a different mechanism of action, but it could be interesting and worthwhile. But for sure, what we have seen is the most frequent medications that are prescribed in the love are valproic acid, levetiracetam or Keppra, and carbamazepine. So Teresa is asking if all truncating variants are loss of function. Yes, because you don't have the channel. So the channel needs to have 5 subunits, And if you don't have one of the subunits, then the channel is not working. So in that case, that specific channel doesn't work. So that's why we assume that all of the that all of the truncating variants are going to be a loss of function. So Rebecca asks, oh, hold on, if keto diet impacts in the outcomes, and if there's a difference between love and GOV. So we don't know because we are starting collecting prospective data right now, and we don't know what will be the impact in the outcomes. But we assume that if you reach seizure freedom and this have some impact on the mm, cognitive and behavioral aspects, then maybe it would have an impact. So we do have patients in GOF and LOVE with ketogenic diet. It's less than 50% chance of seizure reduction in both groups. Of course, with the GOF, it's less likely, but there's limited evidence in that regard. So next one will be Randy. Any drugs that are more useful to the GOF? No, we don't know that yet. As I mentioned before, there are some reports in the literature about conflicting outcomes with clobazam and clonazepam. So you might find a Chinese report that says that the kid with the GOF had a tremendous impact with the clonazepam, but we haven't seen that outside that patient. So we don't have an answer for the GOF, and that's why we're trying to do an animal model of GOF. The main problem is that the survival rate of those animals is not that high, so we need to come with a construct different that's called organoids, where we use the same variant and try to build a mini brain out of stem cells, and then we will test in that tiny brain different compounds and how the network is interacting between all the channels that are related to the epilepsy and the neurocognitive profile. Miranda, do you know how many patients are not presenting with seizures and just having developmental symptoms? Yes, so less than 10%. But I would argue that this number can be higher because we don't know how many of the patients have been tested. And of course, when you have a severe epilepsy, the likelihood of you being tested is higher than if you have, for example, only a febrile seizure. So we do not know if there are more patients with more cognitive behaviors that we have not seen. What we have seen, for example, with regards to the psychiatric symptoms is that catatonia and schizophrenia, it's related to some variants in the GABA system. So we saw a patient with epilepsy that had also catatonia. But with regards to autism and cognitive developmental delay, it's not a one-to-one answer. Hold on, I lost it. Randy, for us, clonazepam was brutal, gain of function. Yeah. So, for example, in Randy's case, you had a tremendous increase in the seizure frequency. So again, we have not seen that outside the Chinese paper that were reported a very sustained and good seizure outcome with clonazepam. Paula, is there a correlation between gamma 2 and cortical focal, supposed focal cortical dysplasia? So the gross answer will be no. What do we know about focal cortical dysplasia is that usually they are somatic variants, which means that only a restricted number of cells can have variants. And they are usually, if we're talking about focal cortical dysplasia type 2A or 2B, they have variants in the Gator pathway or the mTOR pathway. But it's not usually related to the GABA variants. But of course, we can have both. We have seen that in Dravet patients that you can have variants in genes that are part of the Gator pathway and also SCN1A. So you can have mixed phenotypes, but it's not usually present in focal cortical dysplasia. Are the results of the studies alpha 1, alpha 3, beta 2, beta 3 um, transferable to other genes? No. So probably transferable to other GABA genes, maybe. We have something called paralogs. So that's how conserved the position it is across all species. So we use a software where we put the location. Remember, you have an amino acid and then a number and then another amino acid. So we use that number to find the location within the protein, and we would know that if this particular position is conserved, which means that it's the same across different species or different channels, then we know that if you have a variant in that specific position, it's likely to be pathogenic and probably can be transferred to other genes within the same GABA. But outside GABA, probably it's not. Um, how many patients with proline 253? Well, Justin, I will have to go to my database. I'm not sure I have that information by heart, but I can provide you with that information on Monday. So Dr. Charles is asking about experience with cannabinoid treatment. So yes, some of our patients have had a treatment with CBD, Epidiolex. Um, and the outcome still is not different from other medications, but we don't have any information with compounds that have THC or other type of cannabinoids, because there are a lot of cannabinoids in the market. So the answer would be that in our database we don't have that information. We only have the information about CBD, the purified CBD, and the treatment is not remarkable. They don't have any major modification in the seizure frequency or the cognitive outcomes. So Danielle, oh, sorry. My daughter is 17, about 9 seizures in one night when she was 9, and she's been seizure free. And she has a beta 2 variant with mainly developmental symptoms. Um, So maybe can you elaborate a little bit more, Danielle, and about your question, so we can discuss that. Okay, Paula. So if the seizures of your child are originated from the focal cortical dysplasia, then the surgical procedure, it's the best option to achieve seizure freedom. But you need to be very, very careful, and the assessments needs to be extremely in depth to realize that the only origin of the seizures is actually that focal cortical dysplasia. So what we do usually when we implant an SEEG is that we stimulate that area with the electrodes, and then we kind of reproduce the seizure to make sure that this is actually the seizure onset zone, so we can ensure a better seizure outcome after the surgery. But then, of course, you can have, as I mentioned before, somatic variants in the tissue that is in the focal cortical dysplasia that you cannot find on the blood sample. So it's advisable for them to do genetic testing in the sample. This is not usually done in several countries. I'm not sure if you're from Brazil, but probably it's a very last Brazilian last name. I was trained in Brazil. So if you are, maybe Unicamp will be the one that tests the actual tissue. So I would strongly recommend that. Or if not, maybe you can email me, and then we can try to find a center that can perform the genetic analysis on the surgical specimen if you go for the seizure surgery, for epilepsy surgery. So another question is if we are classifying variants LOF-GOF or there is an overlap in the variants. Yes. So they have what we call a gray phenotype that has some features from the gain of function and some features from the loss of function. But they're usually not severe. they are in between. They're also not the best seizure outcomes, but they are definitely a group in between. And some of the variants that we have tested, they are neutral. So we don't know whether this is a causative for the disease or not. We are exploring that on animal models. Uh, Lisa is asking what did she take, but maybe it's about another, maybe it's for Danielle, I'm assuming. So Randy ask if there is a GOF, those all type binding site drugs with anti-seizure, anesthetics, ivermectin, etc., should be avoided. Uh, specific variant is related to specific binding site. No external allosteric but channel for allosterical. Okay. Yes. So in some patients, the variant is on the binding side. And when we are having the discussion about the functional analysis with you guys, we usually give you the graphs and we will tell you whether it's on the binding side or not. So that will give you a hint whether these kind of medications should be avoided or not. What do we know? Some of the vast majority of our patients have undergone MRI with anesthetic procedures. Usually they do it with ketamine or maybe a small dose of midazolam and with no major adverse effects. But there is no study in this regard. So what we know is what has happened in before, like they have done the MRI without seizure worsening or so, because most of our kids have already an MRI. For longer procedures, we don't have that information because, for example, gastrostomy or tracheostomy will be even less time that for the MRI procedure. So I would have to postpone to answer you that. Maybe I think we have been in touch about this before, but we don't have enough information to say whether it's binding site related, the outcome or the complications that you might have found. Uh, Miranda, one of Scarlett's biggest delays is speech. So she's a frame shift. Again, a frame shift will be a loss of function. And she seems to understand language but cannot produce sentences. Are there any interventions currently besides speech therapy or waiting on drug repurposing? Yes. So if you go to speech therapies, you will find a lot of different speech therapies, lots of them. So we don't have evidence for a specific one that we can say that it's better or less efficacious to compared to the other ones. But what we do know, for example, if you go for different approaches, is that if you're sure that she understands everything as we have known by our interviews, then we will argue that in the meantime we should go for a different type of communication while we develop something new. Um, we have seen some changes with some specific therapies that are related to the hypotonia they might have around the mouth, but this is only for one patient, so I don't know if this can be extrapolated to the rest of the patients. Portugal, Paula. So yeah, well, I have a neurosurgeon that I know in Lisbon, so maybe I can put you in contact with them. Uh, it was kind of piggyback of um, so Agustina is asking about vinpocetine and verapamil. So we are actually conducting a study on vinpocetine here in Denmark. We are including patients with pure vinpocetine. So we are not using the OTC compound that you can find in online. So it's only vinpocetine. And one of the major things that we need to have into account when we are using vinpocetine is that they can have severe headaches, uh, this symptom called tinnitus, that it's a strange sound in your ears, and also the interaction between valproic acid, clobazam, phenobarbital, and vipositin and CBD. So if a patient is under one of those three treatments that affects this enzyme in the liver, caution is advised, and then this should be done only by a medical treating physician. And also, what we don't know is for how long should we treat the patients, because of course uh, we know when to start, but probably not how for how long, and if there will be a long-term adverse effects related to timpositin or verapamil. So, for example, in the cases that we have advised to use vinpocetine, we have tested the variant in this oocyte construct that I showed you before, and then we have shown that this rescued the phenotype from the loss of function to a neutral function, and in that case, uh, we advise to use it with caution and only if we are connected to the clinician, so we can be sure that an adequate assessments are done. Yeah, Dr. Scouten. So it's about the family that probably has a loss of function. Some of the family members are affected by some febrile seizures or maybe some seizures. So the suggestion in this case, we would have to test the variant in your grandson, because there is different phenotypic expressions within, especially gamma 2. So in gamma 2 families, we can have a broad spectrum that goes from simple febrile seizures to autistic spectrum disorder, or to a very severe phenotype, Dravet-like phenotype. So in that case, we need to test the variant beforehand, uh, in order to give an advice on the medication. But we have the records of your son and your grandson, so we are looking in depth into those records. Randy says that there are another patient with an impaired binding site for a sedative drug. Yeah, and I think it was related to this adverse effect on malignant hyperthermia, if I'm not wrong. The position on the older variant, and again, there is a lot of confusion whether you can use it or not. And in that case, if it's mandatory, probably inhaled anesthetics will be the best, but then the anesthesia team will be the best who to give you an advice on that regards. So Lisa is asking if impositin is for gain of function. No, it's not for gain of function, Lisa. It's for loss of function. So we have seen in some of our patients, one in the UK and in others in the States, that they have tried vinpocetine in a gain of function with not improving in any aspects. Actually, some of them continue to have the same amount of seizures. So it will be advisable to be used only in the cases that have loss of function and a proper testing about the drug. So Randy, about lamotrigine, we do have the info, but it's still in evaluation if lamotrigine will be useful in gain of function. But most likely it will be one of the medications that it's the most often used, and probably with some effect as levetiracetam. But we don't have that answer yet. Um, so Teresa, I'm sorry, I know you emailed your question, but I had to switch my computer, and the access to my Philadelphia email is on the other computer. So your daughter has a gamma 2 variant, which is also, as you can see in this transcript, it says TER, so it means that it's a truncating variant. And she has had a lot of febrile seizures, some of them complex, and one afebrile seizure. She's seizure-free for 2 years on valproic acid, and her pediatrician does not want to stop the medication. as she said, gene means it's structural, so she will always need the medication. It might, yeah. So the question is if she might grow out of it and maybe stop the medication. The answer will be probably yes if you don't have any other um, comorbidities. And we use a clinical calculator when you're with your epileptologist to assess the risk of recurrence at 1 year, 5 years, and 10 years. And when we have genetic variants, probably the likelihood would be 50-50. So if it's seizure free, the EEG is clean, then you will have to talk very, very conscious with your treating physician and reach an agreement because, of course, I don't think it's us that makes the decision. Probably it will be the communication between parents and physicians to reach that 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 answer. Okay. Randy says if there is a sudden stop of the seizures without any intervention, does this reveal anything about the patient? So I would argue that yes, because we have seen that some patients, for example, we have a patient from France with a beta 3 variant with a very severe phenotype with epilepsy with migrating focal seizures of infancy, that it's seizure free. And we don't know why. And the outcome, it's much better than the others that we have in our database. So some of the patients will stop having seizures. We don't know why. That's why we aim to produce the construct on the organoids and on the mouse models to test whether this it's related to the circuit the variants involved in, or there can be another type of scenario that we can be related to. So James is addressing to Randy. Yeah. So the answer is that we don't know about lamotrigine yet. Um, So if you want to send me an email anytime you want, please reach out. I'll be slow responding during these weeks, but I'll try to answer you as fast as I can. And if we haven't had a meeting with you guys, I would love to have a meeting with you and maybe try to answer individually these questions that you might have. So what are the ongoing research projects that we have here in Denmark and in Australia? So we are trying to develop some animal models to test possible treatments and outcomes and see if the outcomes can be related to, for example, the variant, the localization of the variant, the medications that have been used in the variant, or other type of things that can be related to the outcome. Um, so we will also construct organoids here in Copenhagen. And as I told you before, organoids are small brains that are derived from the variant that we know that your kid has. And then we will build a mini brain out of it and try to test how it is connected and how the development of the synapses and the response to treatment will be in different scenarios in a very unique way. So for those variants that we have not tested, we are going to test them as soon as we got the transcript. That's why we need to have an interview with you guys and know what the variant is. And if we had already in our database, then we can provide you with some extra clinic information. After that, in the meantime, some of you have sent a questionnaire about movement disorders because we have seen, especially in the GOF patients, that they have a severe movement disorder phenotype. So there is a script on how to take the video. So we will analyze the video with some experts from the Great Ormond Street Hospital in London to provide proper diagnosis and then probably some specific treatment to the movement disorders, because sometimes it's not the seizure, it's about the movement disorders that is affecting severely the quality of life. Also, to some of you, we have distributed, and I will distribute it to Justin, some sleep disorder scales, so we can assess how does the kid sleeps, because we do know that in some cases the epilepsy phenotype. Yeah, I can put that in my email in the chat, Diane. So we have seen that refractoriness in the epilepsy field can also be increased by sleep disorders, especially sleep apnea. So we need to know whether our kids have sleep apnea, and in that case, how hard it is, and if you can treat them, maybe we can increase or improve the outcomes, whether it's on the epilepsy field, but also on the cognitive and behavioral issues. Um, we have asked most of you to see the EEGs because we think that there might be some fingerprints or some specific findings that can provide some hints before the genetic testing. So we do know that for some KCNT1 in neonatal onset, some for the SCN8A, that if you have some features, then you, with a very strong prediction, will have a GABA or a sodium channelopathy or a potassium channelopathy. So that's why we're asking for the raw EEG so we can analyze them and try to put some time effort in analyzing those data. And then, of course, we will describe the current treatment of our population to see which medications are efficacious, which medications are need to be avoided, and what other medications we can try. So in that regards, we will also circulate a survey on how which treatment you have received and what will be the response you have had, so we can have an information from your end. Because when we go, for example, for the articles that have been published, this information is limited. When we go to the physicians, probably they don't know by heart the month of initiation and the outcome of the medication, but you for sure will know all about this. So, do you have any other suggestions on research points that we should address at this point?
Real quick, I would say with a lot of the parents we've been talking to lately, we've been seeing a lot of connections between GI disturbances and immune response, changing the seizure patterns for periods of a month to maybe 6 months, such as going from 50 seizures in a day to 0, when these GI or immunity issues come up, or when they're resolved. So we're seeing that it seems to modify the disease presentation significantly in some more of the severe kids.
Yep. Yeah, we need to know how to address this GI, but definitely we need to take a look at that. And also, I forgot to mention that we can do interviews in English, Danish, German, Italian, Portuguese, Spanish, and French. So, because sometimes people reach out and they are afraid that we might not be able to speak in their own language, but we can at least speak in our lab. We have a lot of and Georgian as well, and Russian. So we can provide with some other approach. So lastly, I want to thank you for giving me the opportunity to have this discussion. For me, is amazing to be in contact with the parents, and I know we don't have a lot of answers, but we're doing our best to provide you with some answers in these regards. And on the heart shape, there's not only one, but it's a group of people, very smart and dedicated, that are working tirelessly to provide you the answers we need. And please reach out if you have any questions or comments